afternoon, everyone, and welcome to this year's 2021 Matrix and GP Track Summit. It features disruptive technologies and innovations. During this poster session, we'll have 3 posters presented that outline projects in telehealth, and they'll give you insight into innovations and present some new ideas for you all to consider. Detailed data gathering and research into each of these areas is what makes undertaking telehealth research very beneficial to all of us. We're grateful to our presenters who are willing to share their findings and know that you will come away with a better understanding of telehealth. Each presenter will be given 10 minutes to introduce themselves and explain their poster, with the remaining 4 minutes left for questions and comments. If you prefer, you may use the chat feature on your screen to ask questions. They will be addressed at the end of the 10 minutes. In order to make sure all our presenters are allowed time to present, we will stay firmly on the 14-minute schedule for each. So our first poster, we invite you to proceed.
Yes, I do believe it's us. So.
It would be UVA patient preferences on telepsychiatry. It's you.
Sharing it. Can everyone see this poster? Okay.
Yeah.
Great. So I can't see my face, so hopefully I don't look too weird. My name is Prashant Sen. I'm a UVA medical student at UVA, and I'm here with my research partner, Mary Pang. She's a UVA undergraduate 4th year, and both of us spent the last half year working on this project relating to UVA patient preferences on telepsychiatry during the COVID-19 pandemic. Basically, what we wanted to explore was how patients had to adapt to still seeking out psychiatric care during the pandemic when everyone had to be quarantined and social distance, but still needed to have the much needed mental health resources. And UVA had adjusted to this by doing telemedicine appointments. And so we collected information on which patients had been seen before the pandemic, when they had been seen in person, and also seen for virtual appointments, and seeing what their preferences were on different aspects of these telepsychiatry appointments. There's 6 things that we looked at for the survey. There was their preferences towards or against telepsychiatry, the ease of convenience, perceived safety involved with virtual appointments, if they felt understood, and if they were able to be emotionally open with their psychiatrist, and also their feeling of connectedness with their therapist. And so all this was to have some quantitative data on how they either preferred or didn't prefer virtual appointments compared to the in-person ones that they had before. And so Mary will talk about the results.
So we basically contacted 67 patients, and we received 240 responses, which yielded to a 28% response rate, which we considered a pretty good response rate. And middle-aged, white, heterosexual, cisgender women constituted the largest sample populations. So we began our analysis by computing participants' mean scores of the 6 dimensions of telepsychiatry we just mentioned on a scale of 1 to 5, 1 being the worst and 5 being the best. And One-Way ANOVA indicated that age, gender, employment status had a significant influence on patients' preference towards virtual appointments. And specifically, employed, middle-aged, and female patients showed a more favorable attitude towards telepsych sessions, primarily due to convenience, the feeling of being understood and heard, and the willingness to open up during their sessions. And based on intersectional analysis, patients and therapists' gender match and patients' age and gender affect their attitudes towards different aspects of telepsych sessions. So overall, patient-therapist gender match contributes to a more favorable attitude towards telepsych sessions, and among patients with a female therapist, female patients felt more connected to their therapist than male patients did. And among patients with male therapists, male patients felt more understood and heard by their therapist than female patients did. And lastly, middle-aged female patients showed a more should overall like higher preference score towards telepsychiatry sessions. And our study did not show that race, sexual orientation, or the number of dependents as significant influences on patients' experience.
Yeah,
so
so thank you,
basically,
Mary.
there was limited research on the correlation between patients' specific demographics and preference for telepsychiatry, especially during COVID. So our research wanted to address this gap by looking at the correlation between demographic characteristics and their score of telepsychiatry.
Yeah, of course. And it was nice that so many people were willing to answer the survey. I feel like when I have so many emails, I just let them all push to the side. But this observational study was able to promote, at least the patients who did respond seemed to appreciate telepsychiatry for its convenience and for its feeling understood, and shows that it can work as a viable model of receiving psychiatric care, even when you need to be social distance and can't see people in person. We do realize that there are some limitations because it's a voluntary survey, and the response rate was 28%. There's still a fair number of people who didn't respond, and perhaps their opinions could have been different. And so but in general, this ability to collect data on patients and see how they prefer it is a good proof of concept study, so that if we wanted to expand it to other months during this extremely long year, and seeing how opinions change, if people kind of got tired of being virtually, or if they ended up feeling it was even more convenient later on, it would be interesting to see. So perhaps in the later times we could delve into that information. But in general, we were very thankful to Dr. Richard Merkel and Mariana Araujo of the UVA Psychiatry Department, who helped support us and give guidance during this project. So thank you for your time.
Wonderful. Looks like we have plenty of time for questions. So I'll start with one. What do you see your future in terms of, how do you see your future with telepsychiatry? How did you perceive it, both of you?
So as a medical student, I will be in the medical field. I'm not pursuing psychiatry, but I believe that mental health is important to be addressed in pretty much every specialty. I do think there's a lot of benefits in terms of flexibility and accessibility for telepsychiatry. Granted, not everyone has access to internet all the time, and you would have some limitations in that regard. But in general, if someone lived so far away that they couldn't always travel back and forth to see their psychiatrist in person, I think this is a really good option in order to still have the ability to work out some of their problems or just anxieties. And I mean, this year alone has had skyrocketing amounts of anxiety and depression, rightly so. So I think not having the ability to address these issues is better than having it be bottled up, and kind of people get secluded and feel even worse about themselves and about the world around them. So I think it's a really awesome technology, and I'm excited to see how it grows. I think UVA had been tinkering with using like group Zoom session, or not Zoom, but group sessions, so that people could talk in a discussion board, or other forms of psychiatric care that will probably evolve as time goes on. So
yeah,
almost Dr. Peng.
Sorry, go ahead.
No, go for it.
I was just gonna say I totally agree, and I think COVID has fundamentally shifted how people perceive how medicine could be conducted and how medical services could be delivered. And I think the future of telepsychiatry is definitely promising. But I do think one area to look at is security, because based on the feedback we collected, a lot of people voiced their concerns about security, especially with like online appointments and people like, or therapists they never knew before. So I think the future is definitely promising, but I guess the concern with security also ushered in many new opportunities for pharmaceutical companies and public health the entire public health industry to see how technologies and human services could integrate in a better way to promote like a better future for telepsychiatry.
It sounds really promising. Did you all sense any cultural differences in acceptance of the technology and whether someone might be interested in participating?
I think that was also, I do believe so. I think one of the limitations is that the majority of respondents were white, middle-aged women. And so I think that could have been, because when we look at the actual demographics of the patients that we're seeing, there was a probably bigger diversity of patients. I think that could go back to the point of not being able to like access their email or not be able to fill out the survey. But I think that was something that Mariana brought up a lot, was how different ethnicities perceive mental health and how accessible and how they feel in terms of like cultural understanding of pursuing like treatment or even just different social stigmas regarding mental illness. So I think it would be fascinating to see what their perceptions of it, or what their perceptions of telepsychiatry are, or perceptions of just psychiatric care in this new age that we live in would be.
Some great future research. I want to be sure others have a chance to ask questions. And
yeah, I'm not sure if I heard, did you look at diagnosis in your study at all?
No, we didn't like ask
depression versus psychosis and different, and how people might have perceived the services differently based on that.
No, we didn't ask the individual parties to say what they were being treated for. We felt that would be a bit too intrusive. But I think it would be interesting to see if how their perceptions changed based on like what they were being treated for, or how severe the illness is, or how debilitating it was for them. So it's fair.
Do you have any opinion about that, Dr. Weintraub?
I think as we kind of develop these strategies, trying to pinpoint and personalize who telepsychiatry may not only work better for, have efficacy, but what patients or individuals can tolerate it. We might be able to target how we roll this out a little differently. Make sure it's patient-centered. That was my only thought. So I think this is actually a great first step in seeing overall acceptability, and then maybe trying to kind of what they're doing with antidepressants now. They're trying to personalize treatment and see which antidepressants may work for certain individuals based on their genetic profile. So that's kind of what I had in mind.
Just going off that, a super quick comment. Even though we didn't ask for their diagnosis, we did ask the patients to fill out their specific session type. So there were 3 different session types: it was group session, medication management, and psychosis therapy. And based on our ANOVA analysis, there was no significant difference among patients who went to like different sessions and how they rated their telepsychiatry sessions.
Thank you.
Mm-hmm.
So any more questions from the larger group? These are great questions.
I just wondered if you could say a little more about how you selected the questions that were used, like if you, what you learned looking at the literature, kind of other patient questionnaires, or created your own questions. I think as we think about, to Dr. Weintraub's point, how we better understand our services and improve, kind of do quality improvement, all of us, as we're moving forward with tele. Just if you could speak a little bit about what you learned, how, if you did this again, would you change the questions you used, what you learned in reviewing the surveys that have been done previously?
Yeah, of course. So the first few questions were definitely just demographic questions. I think something that we noticed really early on is we wanted it to be as non-judgmental and open as possible. So in terms of what your gender is, what your how you self-identify, I think we wanted to give as many options as possible. And even I think something that was brought up a few times is, even though it's a voluntary survey, the ability to say, prefer not to answer a question was definitely important for us to include. So the first few were demographics. And then when it came to the patient preferences questions, I think because we wanted to have it be a quantifiable answer, it would be, as Mary said, a 1 through 5, being 5 being you truly prefer telepsychiatry and 1 being you prefer inpatient. And so perhaps like there could have been some confusion in terms of interpreting that question. And if you didn't really have a certain feeling either way, how you would differentiate between a 4 and a 5 or a 2 and a 1. So that was generally how we framed these questions. Yes. Yeah.
Sorry, I think we ran out of time.
No, that's okay. Thank you.
We're good. We have about 3 more minutes. Anyone else have a question? I'll ask one of an audience member. Dr. Weintraub, you mentioned about genetic profiles. That is fascinating to me. I know 3 minutes isn't long to talk about that, but what did you have in mind?
Well, with antidepressants now, they're trying to, not only antidepressants, but even with all medications, they're trying to find genetic profiles that see if certain people respond to certain medications based on their genetics, which kind of plays out into how they metabolize and respond to drugs or to, I should say, medications. And I think that's even true for drugs of abuse. We know that certain people are more likely to get addicted to, for example, opioids because they may have a genetic predisposition. And what is starting to happen is you can actually get, and I'm not an expert on this, but you can actually start getting a blood test to see if you may respond to a certain medication. And it's a bit expensive at this point, and it's still a process that's being refined and not readily available for all medicines. But that's kind of the direction that we're going in, that we're starting to realize that not all patients respond to the same medications, and why do certain people do and why do certain people don't. So that's kind of what I was referring to.
So yeah, that's interesting. I've never heard pharmacogenetics related to acceptance of telehealth. That's pretty novel.
Well, I was just thinking more of that and less about the genetics here, but it's kind of the same philosophy that there may be certain populations, not based necessarily on genetics, but based on symptoms and how people accept and do. Like you might anticipate that somebody that has a paranoid disorder may be less likely to do well with telepsychiatry based on him being concerned about a variety of issues due to his diagnosis. I don't know if that makes sense, but that's kind of what I was thinking. Yeah. Well, somebody with depression and anxiety, especially somebody with anxiety that doesn't even want to leave the house, may do better and want to be involved in telepsychiatry. So that's kind of what I was thinking about.
Great. That has a lot of application to education also, and Zoom anxiety. So thank you. That was a wonderful poster. You did a great job. And we're looking now towards our second presentation. Dr. Coble, I guess, are you going to put yours up?
Yes, I will hopefully do this in a seamless way.
If you have troubles, I can help you with it too.
Is it
yeah, up? There we go. Great. Beautiful.
Okay. So thank you. That may be a hard act to follow, but I will kick us off, and then I will turn the second part over to Dr. Weintraub. So my name is Kelly Coble from the University of Maryland School of Medicine. And I have the privilege to serve as the director of our telemental health program in the Department of Psychiatry. And we're going to talk today about the implementation of a telemedicine program for medications for opioid use disorder in a rural jail. And we moved ahead with this implementation during COVID. So we'll talk about our first pilot of 7 patients and some of the challenges and lessons learned during this early implementation. So I will talk about the pilot phase, a bit of the discussion, and hand it over to Dr. Weintraub for the clinical and medication piece. So since 2015, our Division of Addiction Research and Treatment in the Department of Psychiatry has been providing telemedicine services across Maryland. And I know we're connected regionally, so you might have a visual in your head of what Maryland looks like. but most of our telemedicine services have been aimed at serving rural areas, increasing access to treatment. So out in the western part of our state, which is sort of the skinny part of our state that heads out into the mountains, and then down on the eastern shore of Maryland. And since there's really a lack of, in some counties, a number of our counties, no providers that have their waiver and are able to prescribe buprenorphine, this is why our services have been aimed in these regions. And in a focus, an aim of ours is to help rural detention centers prepare for HB 116, which is legislation in Maryland, to prepare by 2023 to have the 3 medications for opioid use disorder available in detention centers and jails across our state. We received funding through the FOR Foundation, the Foundation for Opioid Response and Efforts, to prepare for HB 116 and partner with detention centers to provide medications for opioid use disorder in some rural detention centers. So this describes our first implementation in Talbot County, which is on the mid-shore of Maryland. So again, if you think about how Maryland is shaped, that's coming down with the Chesapeake Bay coming up in the middle, and we're on the mid-shore. And as folks might know, when folks are incarcerated, we know opioid use disorder is highly prevalent, right, in patients that are in the criminal justice system, and that as folks are discharged, overdose is a leading cause of death in that time immediately following release. So for all of these reasons, we were particularly interested in expanding our teleservices into this patient population. So we began in August 2020. We had started planning and preparing before that, but COVID arrived and caused some challenges for implementation. So just the logistics of having meetings in detention centers, COVID outbreaks in detention centers presented some challenges, but our team moved ahead. So logistically, for folks that might be thinking about something similar, some of the workarounds or adaptations we made was having to ship laptop into the jail. We couldn't deliver and install our cart because our team couldn't arrive. So you can see pictured there the cart that is still waiting, but really access and staff meeting in the detention center has been delayed. We haven't been able to do that, but our IT team worked creatively and we had other equipment arrive and we were able to launch in 2020. We have had favorable initial outcomes, which we're pleased with, but a small population. We've had 100% acceptance rate of the 7 patients we've been working with, all 7 individuals that have been offered treatment. So Dr. Weintraub is our lead on this project with Dr. Welsh working alongside him, have accepted treatment. And 2 of the patients who initiated treatment were able to continue upon release. So we have a team of care working with care coordinators in the community and a care coordinator on our team that then follows folks into the community to try to ensure continuation of their medications upon release. And Dr. Weintraub will talk a bit about how we work with the pharmacy, the nurse within the detention center, and try to ensure good quality of care upon discharge. We did have 1 patient who received treatment, but again, that's just a small percent. We'll see how this continues. Eric, I will pass it over to you to talk a bit about the medications and the prescription and order writing, because I think technically that's an important piece to cover.
Okay, thanks, Kelly. So as Kelly was saying, we been treating individuals with opioid use disorder in rural areas through telemedicine for about 5 years. And we kind of, over the years, even prior to that, we have a lot of experience with OUD treatment, that our patients tend to travel from outpatient clinics to sometimes they get incarcerated, even if they're doing well on old charges, or show up in hospitals. And we saw that people that are getting incarcerated were not being treated with medications or being taken off their medications. And there's a national movement to try to prevent that from happening. As Kelly said, that these individuals, when they get detoxified in jail, lose their tolerance and are at high risk for overdose when they get released. So what we did was, as Kelly went through, we set up this telemedicine program, and it's a little bit different for us because we were working in a different institution. You had to work with the warden and the line staff, and also with the medical team, which right now is the same in all of the jails we work with. It's a group called WellPath. So we had to talk with the warden to make sure the patients could get transported down to see the nurse every day. We had to work with the nurses to make sure that the patients could get medicated. We actually developed a system where patients were screened. We would do next day. We were available for 4-hour periods, Tuesday through Friday, because that's generally when patients would, they would frequently go for bail hearings Monday afternoons, and we would know whether they would be in the jail by Monday afternoon. So we'd be available Tuesday through Friday to do evaluations if they screened positive. And we developed screening tools and did urine toxicology screens to make sure they did. We would do our full evaluation, and we were able to do that on our own electronic medical record that we use, which is Epic. Make a determination if the patient had opioid use disorder and would benefit from medication-based treatments. In this case, we could not use methadone because of regulatory issues, but we could use buprenorphine. So we would be able to start people on buprenorphine. The way it worked, we would have to do two things as a physician. Once we made that determination, we communicated with the nurse. We set up a order, so she would give us her order sheets, and we'd have to create an order. But we'd also have to write a prescription and send it to the pharmacy that they worked with, so the pharmacy could deliver the medications to the jail. We were also able to get funding to help pay for the medications. So we'd have to work with the health departments. The health departments would work with the jails, get the funding, order medications, and it'd be delivered to the pharmacies. So it's actually been relatively seamless in the jails. Each jail is a little bit different. Even though we're only operating in one, we've been to several, and we're about ready to pilot this work in a couple different jails, one that is much bigger. So depending on the amount of nursing care or staff that a facility has, you may be able to dose patients once a day or twice a day. Talbot County was a small jail, but they were even willing to do it twice a day if we felt like it was needed. One of the biggest issues that we were concerned about was what would happen when patients left the hospital, were released from jail. Would they be able to get treatment? And that's actually been the biggest issue, to make sure that we're able to link people to care. And people disappear from the jail pretty quickly, in the sense that they may be there one day, have a bail hearing, and they're gone. And so one of the things we focused on, I know I only have another minute before questions, was that we started from the first time I saw a patient. I wanted to determine if the patient wanted to be on maintenance treatment, where he lived, and we would start looking for a referral source as soon as he was discharged or released from jail. And we are willing to write bridge prescriptions for a week or 2 weeks, or until the person can get to their next treatment site. And that has been worked relatively well, although sometimes these individuals have not. If I give them 2 weeks, I might get a call in one instance about 13 days later saying, I'm about to run out of medication. I haven't had a time to get my follow-up appointment. What should I do? And I'm just going to end there, because I think we're about out of time, and see if there are any questions.
Perfect timing. Any questions?
So this is one, I just was fascinated by the fact that you guys are able to do this at the jail, and we're using technologies. But you said that you weren't able to get the cart in, and if that was the correct thing, what was your, I'm curious to hear how you adapted to having the virtual appointments.
Yep, just correct. So because of COVID, it just was a matter of timing that prevented us from being able to be in person. So typically with an implementation, we spend some time at the originating site talking about planning workflow, thinking about changes that might need to be made, and building a relationship with the team when possible. Our state is not terribly large, so we like to do that. And because the detention center really had to lock down their was a COVID outbreak, as I mentioned. Fairly early on in the project, we were not able to go in person, and we weren't able to have our IT team go and install the cart as was originally planned. So we shipped a laptop, and our IT folks called and just walked through, kind of did some step-by-step walking through. Another challenge in the detention center. So you heard Dr. Weintraub mention detention centers. This isn't the only site we're working on implementation with. This is the site we're the furthest along with. But they all have space, constraints around space and staff and supervision of inmates within the facility. So we have to be mindful about the type of equipment that's being used. So the cart isn't terribly large, but there are lots of just rules and regulations about what can be installed and where it can be placed. So we're hoping to use a cart, kind of like you see in that small picture on the poster, in all of the sites if space allows. But it has to be secured and installed in a place that works for the director and the wardens. So it was really just because of COVID that we had to ship a laptop that they felt would work in the space, and the cart is waiting in our office to be deployed when they're comfortable with it. Because these are small county detention centers.
No, of course, yeah, that makes sense. Yeah, we've used similar carts in the emergency department, but I was thinking, I was like, oh, maybe they like gave them an iPad or something that they could use. But cool, I mean, laptop works. You make it happen. So yeah, that's awesome.
Hello, hi guys. I have a question. A very interesting study. Is this supposed to replace the physicians that they're actually working in the detention centers or the detention clinic?
I think at this point that the issue is that, the issue is that to be able to prescribe buprenorphine, you need to have a waiver. And it's not a huge problem, but it's a barrier. Probably about 5 to 6% of physicians in the United States are waivered to prescribe buprenorphine. And it's an 8-hour training for physicians, 24 hours of training for a nurse practitioner and a physician's assistant. And many of the physicians in the jails do not have the waiver. So I think the goal as you move forward would be able to, and the other issue is the reason we're doing telemedicine at all in these areas is just a lack of waivered providers in all of these rural areas. So the goal would be to try to train more physicians and encourage them to get their waiver. But for some reason, there's a stigma and some fear associated with prescribing these medications to people that are addicted. So I think things would be better within the jails if we had more waivered prescribers. But at this point, the jails that we're going into do not have waivered prescribers. I don't know if you want to add anything, Kelly.
No, sorry, Ellen.
No, I think we're at the end, but
oh, sorry.
But no, don't be sorry. This was a great discussion. I wish this could go on for a long time, and it might if I can't locate the third poster. So
I will just mention that to Dr. Weintraub's point, our colleagues of ours that are on another team of ours presented a poster on the Max Tele-Echo Clinic. Our state has an access program to increase the number of waivered prescribers in Maryland. So if you're interested in that point, Sarah Sweeney and Vivian Huang from our team presented yesterday, I believe. So we are trying to address that as well.
Thank you, and thanks for the great question. Okay, so now I'm going to ask for the next poster, Virtually Imperfect. It's titled, is the person here? Looking for Dr. Dang or Dr. Lamba?
Hi.
Oh, there you are. Thank you.
I just sent you a message to say I'm on. Imagine I was having technical difficulties logging in.
And you are I'm
Dr. Dang. I'm a geriatrician.
Dang. Thank you.
MBA, and do some research in telemedicine and among other things. As you mentioned, the title of our presentation is Virtually Imperfect, Use of Video to Home for Frail Older Adults During the COVID-19 Pandemic. we all know that, you know, the United States healthcare system overall and the VA very specifically kind of shifted to doing a lot of virtual stuff as soon as the pandemic hit. The VA has always been a leader in doing virtual care and you know, but this was a unique opportunity that presented itself, so they took great advantage of it. But I wanted to kind of go back and look at the patients to whom we did offer virtual care and see how that worked out for them.
Can I interrupt you for 1 second? Would you be able to share your screen for your poster, or do you want me to try?
No, I got it.
Got it. Beautiful. Thank you.
So we run a frailty clinic. It's frailty intervention and treatment. It's the FIT clinic for high need, high risk veterans. And high need, high risk veterans are those that are identified by a central office in the VA, patients who are at high risk for being hospitalized or being institutionalized and in need of additional services. So we run a clinic specifically for this group. And in March of last year, we started offering them virtual follow-up. So, you know, they couldn't come into the VA as everything was shut down. So we asked them if they would be willing to see us virtually. We called the first 111 patients that were registered in our clinic at that time. We called all of them follow-up. So nobody knew. These were people who had already accepted to be seen in our clinic and receive follow-up. So what we did here was that we kind of wanted to track, you know, the service being offered and how many people were willing and able. It's relatively quite simple compared to the 2 posters that was just presented. So just bear with us for that reason. It's really a counting of numbers. And we compared the characteristics of the people who completed a video visit, those that scheduled a visit but then couldn't complete it at the last minute or didn't keep the visit, so there were no shows, and those that couldn't be reached. And we kind of did the appropriate statistical tests and then compared their parameters. So here on your screen to your left, this is the first table. And in this table, we compare the characteristics of people who completed a video visit, people who were reached but then opted to do a telephone visit, or those that agreed to do a video visit but couldn't do it on the last day, those that were contacted but didn't want to visit, and those who we were unable to contact. You know, so it's just a basic breaking down of the characteristics of the people. There were really no differences between these 4 groups in terms of their. We did see none of these particularly significant, just by, you know, based on the numbers, because so small. People who were not able to be contacted, more of them African American. And then we also calculate in our clinic, because it's a frailty clinic, we calculate a Rockwood Frailty Index, which is a composite index that's derived by multiple factors that go into it, that include physical factors, social factors, psychological factors, functional ability. We do a lot of assessments, etc. And it's calculated based on all. So this Rockwood Frailty Index tended to be higher among the people that we were not able to contact, as you can see where my laser is pointing. Again, not statistically significant people who were frail, probably in need of greater care, were the people that we could not contact to be able to invite them to a visit. So that whole set of questions that the healthcare system needs to answer. And then we also looked at their frailty indices. This Gen Frailty Index is another index that is often used to calculate its functional ability, and a lot of other factors go into this as well. And CAN score, which is assessment needs, again, another frailty index kind of number. So there are no big differences in these. But again, all that we saw were the people that were frail, we were less likely to be able to reach them, and African American, we were less likely to be able to be contacted in this group. And then what we also did here, we also looked at people's, the 111 that we did try and reach. And among those people, we were able to reach 73, and 67 of those agreed to be scheduled for a visit. I am going to see here. And among the ones that were able to reschedule, 36 of the ones, so 36 of the 67 had the technology for a video visit. So they said, yes, we have a video, we have a camera, we have internet access, etc. So we have a very specific set of questions that we asked, and they said they to have the technology for a video visit. Some of them still preferred to use a telephone. They were scheduled for a telephone visit. Among those who had the video capability and were scheduled, so were 41% of the people that we reached, the 67, and we scheduled. On the last day, when we actually did a visit, only 19 of the 28 were able to complete a visit, so about 2/3. So in the end, we see of the ones that we scheduled for a visit, only 20% of those people were able to do a visit. And that the whole questions about people who actually have poor access to care, and we all talk about how virtual care can actually compensate who have poor access. This brings up the question of whether that is true and what are the structural changes need to occur for that to actually happen. So while the VA has done a great job in leveraging technological capabilities and transferring routine care that was face-to-face virtual care, so people who lacked access could actually have this. This doesn't come through when we look at the numbers in the frail older population. So, there's several frail minority older adults who lack the tools, willingness, and ability to do video visits. And it really is imperative for us to understand and address how to help these frail older adults to improve their access. And I guess we need to focus not only on disparities in digital access patients, but really look at some other innovative care models, perhaps using community health workers or peers to act as telepresenters and other system level changes that need to occur to address this digital divide. And that's all I have.
That's perfect. Thank you so much. Another really important study. How about questions from the audience or presenters? We've got 4 minutes for that.
I have a question. This is a very nice study. Did you stratify those patient population, their socioeconomic status when you did your analysis? Thank you.
That's an important question. We did not stratify them by socioeconomic status. I mean, what we did stratify them was their frailty level. So whether they were frail, we divide them out into robust, pre-frail, and frail. That, as I said, is a composite index of many different factors that go into it, which includes social factors, but not necessarily the economic factors. So that's why I'm saying we didn't do it. But a lot of these indices that we are, the frailty index, as I described initially, has 40 factors at a minimum that go into it. And that includes their ability to perform their activities of daily living, the instrumental activities of daily living, the social support structure that they have, their ability to perform certain, like a 6-minute walk test, the grip strength, the shoulder strength. So different things that go into it, including, we do some food food insecurity questions as well. So again, that may be reflective of what you're asking, but not really the exact economic status. But I think it incorporates a lot of the things that you may be alluding to.
The only thing that kind of confusion to me is the lack of technology. Now, when we talk about frail older patients, maybe you're talking about inability to use, although they have the technology because of their inability to utilize the equipment. But the lack of the technology, I think that there could be a lot of income related on that, rather than the age or the definition of the frail older adults. That's just my opinion.
No, you're absolutely right. I mean, so just to clarify, the table on the right, of the people, like again, the 6 to be scheduled, only 54% of them said they had the technology. Now, whether the other 46% didn't have the technology, because I mean, it's quite likely that they were economically not able to afford it. So I think that's the point that you're trying to raise. And then among the ones that had the technology, so, were they willing and able to use the technology? So I always talk about the access to technology, the willingness to use technology, and then the ability to use technology. So access, willingness, and ability kind of is how I look at technology in this group. And important point about, the economic probably contributing to the ones that did not have the video ability.
Wonderful. Thank you so much. We're at our end point for this, and there's still a lot of questions I'm sure that we have, but I want to thank, I have a brief closing statement for you all. I want to thank all of our poster presenters and our audience for joining us today. We encourage everyone to vote for the People's Choice poster presentation in the Summit app. Vote as many times as you want now. If you have further questions or you'd like to continue any discussion with the presenters, feel free to connect with them at the Summit. So to do that, review the attendees and then message them to connect at networking tables in the exhibitor space, or just email them. So I just want to say it was a privilege to moderate this program. You're all wonderful. These are really impressive. So thank you so much. We're going to now shut down this session. The recording will stop, and then the recording will start up again for the next poster session. So thanks again. Have a really great day, everybody.